Hello, this is Dr. Tom Murtaugh of the Christ Hospital in Cincinnati, Ohio, on behalf of the International Cardio-Oncology Society. Today, ICOS presents an extensive highlight from a recent webinar. We know you will enjoy hearing this update.
So I thought as broad objectives, I would just mainly review the primary cardiovascular toxicities with VEGF receptor TKI therapy in renal cell carcinoma. But I want to do this mostly from an oncologic perspective. As a medical oncologist, think about how we weigh the cardiovascular or any toxicity considerations with the overall treatment plan for a patient with advanced kidney cancer. And so in order to do that, I wanted to focus on just some of the basic concepts we think about in kidney cancer treatment, really with the focus on the first-line management of clear cell kidney cancer. And then again, weigh some of the oncologic considerations with trying to balance both cancer control with treatment-related toxicity in this disease. So just as some very brief background, looking at the epidemiology of kidney cancer, this is data from the United States looking at incident cancer diagnoses and also cancer-related mortality. We see that kidney cancer is on the top 10 list for both men and women of incident cancer diagnoses in the United States. Primary risk factors for kidney cancer, we see there is some overlap with cardiovascular risk factors, mainly smoking or tobacco exposure and obesity. And then we know there's also a variety of hereditary genetic predispositions to the development of kidney cancer, such as the von Hippel-Lindau syndrome, which can predispose to the development of bilateral clear cell kidney cancers in up to 3/4 of patients. I think one really interesting trend, especially in the Western world, is the rising incidence of kidney cancer that's been observed over the last decade or so. This is actually data from the UK, but I think very similar trends have been observed here in the United States and across most Western world countries, where the incidence of kidney cancer has really skyrocketed over the last decade or so, and importantly is expected to continue to increase in the decades to come. There's not a very clear reason for this. I think some of it is probably attributable to earlier increased detection of kidney cancers, so some stage migration or earlier detection that's contributing to this, mainly because we get a lot of routine abdominal imaging for a variety of different reasons in the emergency room, et cetera, that can pick up small incidental kidney cancers. But I think this has also been tied to some increase in the risk factors, and mainly the obesity epidemic in the United States that may also be contributing to some increased incidence of kidney cancer. When thinking about the histology of kidney cancer, it's important to recognize that it's actually a bucket of many different biologies, different flavors of the disease. The vast majority of patients diagnosed with kidney cancer are what we deem to be a clear cell histology or subtype, so about 75 or 80% of patients. But there are some more rare forms of kidney cancer subtypes that we do come across. So one example of this would be papillary subtypes of kidney cancer, and then a number of other much more rare forms like chromophobe and translocation kidney cancers. Importantly, VEGF receptor TKIs often have a role in the treatment of a variety of these different subtypes, so not only clear cell, but non-clear cell histologies as well. Staging of kidney cancer, I think a couple points I just wanted to highlight are that, number one, kidney cancer can spread almost anywhere. And so if you can sort of think an area of the body, we've seen it in terms of a site of metastatic spread. Although most commonly, kidney cancer spreads to the lungs and to the either thoracic or abdominal lymph nodes. And then the second point I wanted to make is that although we do pick up the majority of kidney cancers in a localized setting, and primarily it's patients presenting with gross hematuria or having an incidental renal mass identified on abdominal imaging obtained for some other reason, because of the location of kidney cancer in the retroperitoneum and the fact that it can sort of slowly grow to very large sizes over a prolonged period of time before developing patient symptoms, there is a substantial proportion of patients, so up to 16% of patients who present with distant metastatic disease and another 16 or so percent of patients who present with local regional disease or locally advanced disease, but not necessarily distant metastatic. And so it definitely, compared to some other cancers, has a higher proportion of patients who may present with more advanced disease. Okay, so what about the management? And just wanted to talk about some broad principles when we think about the management. And this is, again, focusing mainly on metastatic clear cell kidney cancer, where systemic therapies are most relevant. So one important point is that even in the advanced stages of kidney cancer, so metastatic RCC, there's a tremendous variability in the biology of the disease and the clinical behavior. So one way we have to think about that and estimate what that risk or biology may be for that particular patient is what we call the IMDC prognostic risk groups. So listed here are 6 clinical or laboratory criteria that have been well-defined and validated in a large number of data sets across a number of different systemic therapies that we use for kidney cancer. And so this is the main prognostic tool that we use to estimate risk for patients with advanced disease. It's the time from diagnosis to initial systemic therapy and whether that's greater than or less than a year, and then a number of laboratory criteria. So anemia, hypercalcemia, elevated neutrophil count, and thrombocytosis, as well as a clinical assessment of the Karnofsky or similar to ECOG performance status, essentially an estimate of the functional status of the patient. And the reason why this is important is we can use these factors and the number of these factors that are identified to categorize disease biology into one of 3 categories. So favorable risk, intermediate risk, or poor risk based on the number of these factors that may be present. And although this isn't a perfect science, again, it has been validated across a number of different data sets to at least estimate or inform a discussion about what the estimated prognosis may be for that particular patient. And what I've shown here is just some contemporary clinical trial outcomes, and the specific drugs evaluated in this trial I don't think are particularly relevant for this discussion, but what I just wanted to highlight is the difference in prognosis based on these risk factor groups. So if we look at the overall trial population, that's this top Kaplan-Meier curve, where we can see 2-year estimated landmark survival at somewhere around 75% or so in the entire trial population. But when you break that down into the favorable risk patients versus the intermediate or poor risk patients accrued in this study, we see that there's a significant disparity. So in those patients with favorable risk disease treated with the trial intervention, the 2-year landmark survival was around 85%. On the other hand, in those patients with intermediate or poor risk disease, we see that, depending on what trial intervention they received, that 2-year survival falls precipitously, so somewhere between 55 to 69% as compared to 85% in the favorable risk patients. So as a general rule, this does carry some prognostic information about what the anticipated natural history of that disease may be. And the one additional point I wanted to make about thinking about the burden and course of advanced kidney cancer is this concept of metastatic burden. And one, I think, big caveat or limitation of these risk models is they do not directly factor in the metastatic burden. And so I just, as an example, wanted to include 2 intermediate risk patients that I've seen in my own clinical practice and just point out some pretty significant clinical disparity between the 2 patients. So the first patient here listed on the top just shows his cross-sectional imaging. You can see there's a pretty bulky primary kidney mass, and then there's evidence of metastatic disease. There are some pulmonary nodules, but mostly sub-centimeter in size, probably not very symptomatic from this disease, but technically intermediate risk based on the laboratory criteria and his time of presentation. On the other hand, similar patient with almost identical laboratory criteria and almost identical timing of presentation, but you can see not only a very bulky and necrotic primary kidney mass associated with some thrombus, but much more bulky pulmonary metastatic disease, and this patient's more likely to be symptomatic from his disease presentation. So these are other, I think, clinical variables or factors we think about when trying to assess the treatment approach and the prognosis of an individual patient. Thinking more about systemic therapy now, I think, this is probably something that people are familiar with, but there's just been a lot of advancement in novel therapies for metastatic kidney cancer. Um, 15 years ago, we were largely in what people have called the TKI era. So you may remember drugs like sorafenib, sunitinib, so multi-kinase inhibitors that target the VEGF receptor. And while those drugs certainly still exist today, there's been just a tremendous amount of novel therapy development. And really what most people call the current era is really the era of immune combination therapies. So certainly VEGF receptor TKIs play a primary role in the treatment of kidney cancer, and I'll have some subsequent slides on that. But really, we're talking more about combination therapies, oftentimes including a VEGF receptor TKI, but almost always also including some component of an immune checkpoint inhibitor or immune therapy for the treatment of kidney cancer. And so, looking at these consensus guidelines, I thought just sort of two things that are important to highlight are what I mentioned. Number one, combination therapy approaches are really the preferred first-line systemic therapy for clear cell disease. And number two, and I think relevant for this talk, are that really sequential use of VEGF receptor TKI-based therapies in subsequent treatment lines is, I think, is also an important treatment principle in cancer, and I think has some implications for toxicity management. So I wanted to show that a different way here, I guess focused more specifically on VEGF receptor TKI therapies. So I just sort of put, again, the same table, first-line therapy and subsequent therapy for clear cell kidney cancer. But if you then just cross out any of the therapies that do not include a VEGF receptor TKI, you see that the majority of the regimens do include some component of VEGF receptor TKI therapy. And so the preferred systemic therapy for the majority of advanced kidney cancer patients, I think, does include a VEGF receptor TKI. Increasingly, this is in combination with anti-PD-1 or immune checkpoint inhibitor therapies. And finally, prolonged VEGF signaling inhibition. So in the first line setting, but even in subsequent therapy settings, is an important principle in the treatment of advanced kidney cancer. So these patients are having prolonged inhibition of the VEGF receptor signaling pathways. And ultimately, the optimal use of VEGF receptor TKI therapies, I think, it's dependent on maintaining drug exposure and dose intensity, meaning trying to maintain consistency with the medicine at optimal dose levels without the need for a lot of treatment interruptions, dose reductions, et cetera, if at all possible. So, now with that background of just sort of some of the treatment considerations in kidney cancer, of course, wanted to talk about the cardiovascular toxicity considerations, but again, try to think about how we weigh these toxicities in the management of the disease. So I thought I would just present an example case, which hopefully illustrates some of these concepts. So this is a patient of mine, 67. He had a history of a right nephrectomy for clear cell disease in 2022, but now presented with bone pain, had involving the ribs and his shoulder. He had some imaging to evaluate, had new multifocal pulmonary nodules and lytic bone lesions. He underwent a CT-guided biopsy of a lung nodule that confirmed recurrent or metastatic RCC. He comes to a medical oncologist. I see him. His initial blood pressure in the office is 145 or over 85, although is admittedly anxious and also having some pain related to the bone lesions. Past medical history has hypertension. He has CKD with a creatinine of 1.6 and, of course, a solitary kidney after his nephrectomy, and has a history of CAD. He's on baby aspirin, lisinopril, metoprolol, and a statin. And I recommended that we initiate, hopefully quickly because of his symptomatic presentation, both axitinib plus pembrolizumab, so a VEGF receptor TKI plus an immune checkpoint inhibitor for his symptomatic disease. And we had characterized him as having an intermediate risk kidney cancer presentation based on those clinical and laboratory criteria that I showed earlier. And so we'll come back to this case, but this is a patient who had hypertension, CKD, and coronary disease, is on a number of different cardiovascular risk-reducing medications. And so, just recently at the ACC, we presented some data looking at an EMR-based cohort, just trying to assess what is the cardiovascular comorbidity in patients with RCC, and specifically those patients who are planned to initiate a first-line VEGF receptor TKI therapy. So this is a multi-center retrospective EMR-based cohort, about 1,000 patients. It did include both kidney cancer and thyroid cancer, but the majority of patients were RCC patients, and all of whom were about to start their first VEGF receptor TKI therapy. And I think what was striking from this data set, although maybe not too surprising, is that when we look specifically at the RCC patients, the baseline prevalence of cardiovascular risk factors and cardiovascular disease is relatively high. So just looking at the RCC patients and the risk factors, a quarter of patients have diabetes, about 60% of patients have baseline hypertension, another 45% of patients have hyperlipidemia, about 60% of patients have chronic kidney disease. Again, most of these patients have undergone a nephrectomy. And then in terms of prevalent cardiovascular disease, not insignificant. So close to 10% of patients had a history of heart failure. Another close to 10% of patients had a history of stroke. And so I think one conclusion is that the prevalence of these cardiovascular risk factors and disease is quite high in patients with kidney cancer about to start a VEGF receptor TKI therapy. So this is a real world or non-clinical trial experience. And when you look in longitudinal follow-up for these patients, and so this is a long period of follow-up, but a median of around 19 months, we actually observed close to 150 MACE outcomes in these patients, about 48% of which were heart failure events. Another third of the events were stroke events, and then about 20% or so were acute coronary events or needing coronary revascularization. And the timing of these events, because this was such a long follow-up period, but about half of these events actually occurred within 1 year of the VEGF receptor TKI initiation. And so I think perhaps one conclusion from this is that the prevalence of cardiovascular morbidity is high, even at baseline in these patients, and a significant proportion of these patients are at risk for developing adverse cardiovascular events at some point in their treatment course for advanced kidney cancer. So maybe just I wanted to focus a little bit on TKIs and I guess drill down onto some of these toxicities, specifically in RCC. I think people certainly know what TKIs are, small molecule inhibitors of the VEGF receptor. There's a number of FDA approvals. We just talked about kidney cancer and differentiated thyroid cancer, but we see this in less common cancers too. So hepatocellular, certain gastrointestinal cancers like GIST tumors, and soft tissue sarcoma. I think the biology is not only fascinating, but really important here. So this is a schematic from clear cell kidney cancer, where we know that this is the VHL and hypoxia inducible factor signaling pathway. We know that in sporadic cases of clear cell kidney cancer, in about 90% of those cases, there's inactivation of the von Hippel-Lindau tumor suppressor gene. So this is a truncal genetic event in the majority of sporadic kidney cancer cases. And that biology is important because when VHL is inactivated, there is this inappropriate upregulation of what we call the HIF or hypoxia inducible factor transcriptional pathway, even in periods of normoxia. So normally this is induced by hypoxia, but even in periods of tissue normoxia, this pathway is dysregulated and HIF transcription is upregulated. And that leads to a number of different pro-angiogenic signaling factors that are present in clear cell kidney cancer. And so this lends a therapeutic opportunity by blocking that enhanced angiogenesis in clear cell kidney cancer. And of course, this is where VEGF receptor therapies come to play. And so I listed a number of the drugs here, not only for kidney cancer, but for thyroid cancer as well. But along with that sort of inhibition of angiogenesis, there's a number of on-target but also off-target effects, and many of these can be cardiovascular in nature. So there's a number of cardiovascular toxicities associated with TKIs. I've listed them all here on this diagram. I was going to mainly focus on hypertension and left ventricular systolic dysfunction or clinical heart failure, just because I think those are the ones that are most common, but also the most worrisome when managing patients. So for TKI hypertension, we know that this can either be de novo or a worsening episode of pre-existing hypertension, and we see that hypertension is quite common in this patient population, even at baseline. It tends to be an early or an acute rise in blood pressure, even within hours to days of initiating the therapy. It's a class effect across all of these agents, so all those drugs that are listed, and it's dose dependent. And so the higher the dose intensity and dose exposure, generally hypertension can correlate along with that. But it is reversible with treatment hold or discontinuation, although for the reasons we mentioned, we try to maintain dose intensity when at all possible. And the mechanisms, to my knowledge, are still being elucidated a bit, but we know there's some changes in vascular tone from decreased nitric oxide production or increased endothelin or other factors. And to my knowledge, it's not a classic renin-angiotensin system effect, as opposed to some other forms of hypertension. For LV dysfunction, it's a little bit different. So there's this clinical presentation spectrum of LV dysfunction with TKI therapy, anywhere from an asymptomatic decline in left ventricular function to more clinical heart failure, all the way to rare but certainly observed episodes of cardiogenic shock or even death. Part of the challenge with identifying the incidence and reversibility of left ventricular systolic dysfunction in TKI-treated patients is just a lack of studies using sort of prospective echocardiograms, varying definitions of what constitutes left ventricular dysfunction, and also the challenge of tracking symptoms in these patients because of the really non-specific symptoms that can occur in a cancer population, such as fatigue and dyspnea. And so all of this together may have led to an underestimation in real-world settings of what the true incidence and nature of left ventricular dysfunction may be. This is work that Dan had collaborated with us now several years ago, looking at, in a multi-center fashion, a prospective study of left ventricular function in kidney cancer patients being treated with sunitinib, so an older VEGF receptor TKI. This was all without any immune checkpoint inhibition given concurrently. And here we got serial, comprehensive, quantitative echocardiograms and cardiovascular blood biomarkers at predefined time points to try to better assess the incidence and potential reversibility of LV dysfunction. And so what the key findings from this prospective study were that the risk of LV dysfunction we estimated to be around 10%. The majority of the observed LV dysfunction events occurred pretty early within the first treatment cycle of sunitinib. So this is within the first 6 weeks of treatment exposure. At least in this series, all of the patients who had an LV decline achieved recovery to their baseline left ventricular ejection fraction, but this was in conjunction with either a reduction in the TKI dose or, and in many cases, co-management with cardiovascular medications such as beta blockers, ACE inhibitors, et cetera. Around 20% of the patients had an elevation in cardiac biomarkers such as NT-proBNP or high sensitivity troponin, but this didn't really clearly correlate with the LVEF changes. And I just put at the bottom here that this prospective data seems to really nicely align with some of the retrospective series that have looked at this similar question. So there's one series from Stanford that also quoted an LVEF decline incidence of around 10% and also about a 20% rise, or 20% of patients developing an elevation in cardiac biomarkers like NT-proBNP. So, those are the toxicities, and I know people are largely familiar with those. But again, what I wanted to think about is what is the actual clinical cost of these toxicities, and how do we think about that from a cancer perspective? Now, one way of thinking about those, the clinical cost, is the risk of treatment-related mortality. And so here's data from a meta-analysis looking at a number of randomized clinical trials that tested VEGF receptor TKIs in kidney cancer, so close to a little over 4,000 patients. And although the relative risk of treatment-related mortality was a little over 2, the incidence of fatal adverse events attributed to the TKI was around 1.5%. But as I alluded to earlier, I don't know that this is necessarily always the best way to assess clinical cost, because there's other factors that can affect patient outcome besides treatment-related mortality. So I alluded to, if there's toxicity and there's now treatment interruptions, there's dose reductions or delays in dosing, that could lead to suboptimal dose intensity, and that has been associated with inferior oncologic outcomes. And so in essence, it becomes this balance between trying to maintain dose intensity and maximize oncologic outcomes versus toxicity management and health-related quality of life, understanding that this is overall a palliative intent systemic therapy for most patients with kidney cancer. And so how we try to balance these is, I think, ultimately the challenge we face in oncology, and is somewhat dependent on the patient. It's somewhat dependent on the specific toxicity we're talking about. So, again, hypertension may be viewed differently from, horrible diarrhea that's affecting quality of life. But ultimately, these factors like treatment interruptions can certainly, I think, affect the dose intensity and may impair, to some extent, oncologic outcomes. And so how do you balance all? So in terms of management, I know Dan and Joe could probably speak to this so much better than I can, but there are some guidance recommendations about hypertension management, certainly early recognition and prompt initiation of antihypertensives, close monitoring of the blood pressure, particularly in the early treatment exposure period, and multiple agents are often needed. To my knowledge, I don't know of superior agents that have been clearly proven in this clinical context, although these different categories of antihypertensive treatments certainly have potentially advantages and disadvantages. And most notably to me is, again, a lot of these patients have baseline renal impairment. And so thinking about how certain antihypertensives may, help or adversely affect that, I think are one important consideration in this population. A couple practical thoughts about hypertension management. So one, I alluded to earlier, this prognostic value of TKI-related hypertension in kidney cancer. So this is data from now over a decade ago. This was largely studied with axitinib, but has also been validated in other TKI-treated cohorts. But what these Kaplan-Meier curves show is that in general, there's been an association between on-treatment hypertension and improved cancer outcome, and it's hypothesized that this may sort of be a surrogate marker for direct on-target effect of these medicines. But importantly, if you then treat the hypertension with antihypertensive agents, that doesn't appear to attenuate the positive anti-cancer effect that's associated with the development of on-treatment hypertension. So, sometimes we tell patients, if they're getting hypertensive on a TKI, we say, hey, maybe this is a good sign that, you're going to have a nice response to this therapy, but we still need to manage the blood pressure along with that. I think a second practical consideration is this concept of rebound hypotension. This was best characterized with sunitinib years ago, which was dosed on a 4-week on, 2-week off treatment schedule. And so patients would have these 2-week gaps in TKI therapy, and you can see both in normotensive patients and in hypertensive patients, there'd be this sort of wave pattern of their systolic and diastolic blood pressures in the on-treatment and off-treatment periods. Sunitinib's a bit of an antiquated drug, at least in kidney cancer. We don't use it as often anymore, mainly because it's not easily paired with immune checkpoint inhibitors. But I think the same concept would apply to any TKI, especially if patients are getting, treatment discontinuation or getting the dose interrupted for whatever reason. There could be these periods of time when there's a rebound hypotensive effect. For LV dysfunction, to my knowledge, there are some guidance recommendations for monitoring and management of the LV dysfunction, but these tend to be expert recommendations, so there's not a lot of trial level data that supports it. But I think, in general, monitoring the echocardiogram, using conventional heart failure therapies when LV dysfunction is observed, and no clear role for prophylactic therapy with ACE inhibitors or beta blockers, at least at this point. And again, it's a very individualized decision with the cardiovascular provider and the oncologic provider. And in many of the discussions I've had with cardiovascular providers, we often consider continuation or re-challenge of the VEGF receptor TKI therapy because it's important to their oncologic care. And if a patient had an asymptomatic LV decline, this is something that could potentially be co-managed along with ongoing TKI therapy. And then the other point I wanted to make here is just that, there are so many symptoms that advanced cancer patients can have: fatigue, dyspnea. And so I generally have a low threshold for evaluating that because many times it's more related to deconditioning or their cancer status, but we also don't want to miss a potentially reversible cardiac toxicity. So just in closing, I thought I would put, as cardio-oncology providers, as you see these patients, it's maybe good to just be familiar with some of the other toxicities that TKI treated patients can have. Not because you're necessarily going to be, managing them, but just to be aware of them. And I think some of these are important because, for example, if patients are having a lot of diarrhea, fluid shifts, and so forth, as a result of their TKI, could that have implications for antihypertensive use and electrolytes and so forth? So just good to be aware of these toxicities. So I put some pictures here of the hand-foot syndrome, which unfortunately can happen across a variety of different VEGF receptor TKIs. A variety of gastrointestinal toxicities, so diarrhea, nausea, not so much vomiting in my experience, but definitely taste changes. Patients can have weight loss on these medicines. So all things that could, again, potentially affect decisions about cardiovascular treatments. So maybe, I know there's only a few minutes left, but I just put some of my own questions here. And I don't know if Dan or Joe maybe you would want to talk or discuss this, but I think some remaining questions we have for TKI therapy in kidney cancer patients specifically is sort of, again, understanding this concept of competing oncologic and cardiovascular risks. We know that patients are at risk for cardiovascular toxicity, but we also know they have a lethal form of kidney cancer. And so how does blood pressure control improve short and long-term cardiovascular morbidity in patients with advanced kidney cancer? And I think what this may get at is, could we develop cancer-specific cardiovascular risk assessment methods that may incorporate both cancer-related prognostic factors, so favorable risk versus poor risk features, but also cardiovascular-related patient factors to try to identify the patients who may be at the highest risk of a MACE event following TKI therapy initiation. And then I think a final question was, we know from non-cancer populations that intensive blood pressure control translates to improved outcomes, so lower cardiovascular event rates, et cetera. But does that same intensive blood pressure control in kidney cancer patients translate to similar improvements? In other words, what are the optimal target blood pressures in an advanced cancer population, understanding that they deal with different challenges than non-cancer patients? So, fluid status, dehydration, GI toxicities, different comorbidities, et cetera. So I think still a lot to be thought about and learned, but I think that's all I had. So happy to answer any final questions.
That certainly was an excellent and in-depth discussion of the issues related to renal cell cancer and its modern treatment. It was especially helpful to hear the discussion amongst our leading clinicians, which highlights the importance of collaboration between oncology and cardio-oncology. If you have not visited the ICOS website recently, please go and check it out at ic-os.org and enjoy our new features. There you will find information on the organization as well as links to educational resources. With that, we will remind you to treat cancer, protect hearts.